So I'll be talking about a rare and interesting condition which is known as skew deviation. As the name suggests, these are skewed, crooked deviations, and if you don't look for them, you will miss them. So what are these skew deviations? It's a vertical strabismus caused by a supranuclear disorder or pre-nuclear disorder. We have been talking about nuclear, fascicular, and at neuromuscular junction, at the muscular junction, but these are pre-nuclear or supranuclear. So the problem is before the nerve nucleus, and this is going to cause the motility problem. This results from the disruption of autolytic pathways. Now, what are these autolytic pathways? You all know about vestibulo-ocular reflex, that from the vestibule, we have the vestibular nerve, which is going and to the vestibular nuclei in the medulla and pons, synapse there, and the second order neuron will come out, exit from there and cross at the level of the pons, at the level of the sixth nerve nucleus, ascend in the medial longitudinal fasciculus on the opposite side, go till the interstitial nucleus of Cajal. So it's a long way, and if there is a problem along these pathways or adjoining structures, you will have a motility problem, you may have one. So they localize to the brainstem or cerebellum or vestibule, because that is the main part of the brain. The cerebrum part has come later. It is a later addition, you can say, extra baggage. So they are form of the basic brain. Now they are diverse in presentation and etiology, may create diagnostic and therapeutic dilemmas for acquired strabismus, because at times they mix up with superior oblique palsy, inferior oblique palsy, and lot of other things. Now, why a skew? Skew is basically these autolytic pathways are a writing reflex. So, if there is a problem with autolytic pathways on one side, they are important for balance. Like, monkeys, and we can all climb trees with lot of finesse. If you look at those spider monkeys in South America, they hang with their tail and they do all kinds of things. You'll find a monkey hitting a tiger also, if you have seen some videos, and going up from one tree to another. So for this you require very good visual acuity, you require very good cerebellum, you require very good proprioception and coordination. So once this balance is gone, if there is this input is asymmetrical, then you will have a skew. This is showing the autolytic pathways. As we said, this is starting from the vestibule, going to the medulla and pons, crossing at the level of the sixth nerve nucleus and ascending on the opposite MLF. So the lesion, if it is before the sixth nerve nucleus, it will be ipsilateral ocular tilt reaction, what we call as ocular tilt reaction, which has three components: the skew, the conjugate torsion, and head tilt. As you can see, the head is tilted to the left side for a left side lesion. But once it is crossing to the opposite side, the same thing will continue. So lesion can be anywhere from this to the interstitial nucleus of Cajal. It's a long way, and adjoining structures can also be affected. This is showing other things which can be affected, like posterior commissure, which will give rise to pretectal syndrome, INC, which can give rise to nystagmus quite often, and of course vestibular nuclei, and superior fourth nerve is also along. So you have third nerve, fourth nerve, MLF lesions. So MLF will give rise to, what does MLF lesion cause? We have an internuclear ophthalmoplegia. So an INO could be very often associated with skew deviation. So whenever you see internuclear ophthalmoplegia, also look for a skew. That should be one of the messages. We will not go into this detail. You have anterior canal, posterior canal, and horizontal canals, as you all know, and they are supplying particular muscles. The anterior canal supply the elevators, that is the superior rectus and the inferior oblique, and the posterior canals supply the depressors, that is the superior oblique and the inferior rectus. And they are working in push-pull mechanism, that if one muscle is activated, if the anterior canal is activated, posterior canal is going to be inhibited. So it is a push-pull mechanism, and it works in that tandem. Now this just shows that if you have an anterior canal lesion, this will give rise to the superior rectus is gone and the inferior oblique is gone. Now the superior rectus palsy, you can see on the left side, it is going to cause hypotropia, because superior rectus is perised and inferior rectus is activated. So this is going to pull the eye down. What will happen to the right side? The inferior oblique is gone. So the superior oblique is going to act and cause intorsion. There is no antagonizing force from the inferior oblique. So you will have intorsion on the opposite side of the lesion and depression of the same side of the lesion. To compensate this, he will have an abnormal head posture to the hypotropic side. So in the anterior canal lesion, you will have hypotropia and intorsion of the other eye. If you have a posterior canal lesion, the opposite will happen, that the other eye will go hyper because the IR is inhibited, and there will be extorsion because the superior oblique is inhibited, so the inferior oblique is going to cause extorsion. Now looking at this together, there will be a vertical and there will be extorsion of one eye and intorsion of the other eye. Now what we call this? This is conjugate torsion. This is conjugate torsion because both eyes are torted in the same direction. One extorsion, other intorsion, so it is like eyes torted this way or torted this way. Now if both eyes are extorted or intorted, we call it disjugate torsion because both eyes are extorted or intorted. We'll see some pictures about that. This is just showing that you can have skew in three planes. One is the roll, where you have oculotilt reaction, and also DVD. They are basically they share certain things in common. Then you have interoral plane between the two ears, which is going to give rise to primary inferior oblique overreaction or eye skew, which is laterally alternating skew deviation. Means as the eye is going into adduction, it will rise or fall, and both ways. So eye may fall or rise depending upon if it is a primary inferior oblique overreaction or superior oblique overreaction. So these are in the pitch plane. What we call as interoral axis is pitch plane. Then you have the yaw plane, which is going to cause torsion. So an oculotilt reaction in the roll plane, a pitch, laterally alternating skew in the pitch, and a torsional deviation in the yaw plane. So these are in the three axis you can have these movements. Now this is showing a typical case, oculotilt reaction. You can see that there is a tilt to the right side and there is a left hypertrophy. I will just show you next picture, and there is also limitation of, you can see here. This we are doing as part of workup. You have to look at subjective torsion because, as I said, there is going to be intorsion of one eye and extorsion of the other. Very important to look at it because patients may not complain, but once you put the double Maddox rod, that is the best way to look, and simplest way to look at the torsion is putting a double Maddox rod and looking at it. Simplest way, easily available, so no difficulty. There are changes with the supine position with torsion and vertical deviation in skew deviation as compared to superior oblique palsy, for example, where it does not change. So that serves as a differentiating feature. With these conditions, if you are trying to separate superior oblique palsy from a skew, make them lie down and look at their vertical deviation and torsion, which may get better once the patient is supine. So it is just to differentiate them. We are not going into the detail why it happens because there is no time in this. Now this is showing conjugate torsion. You can see, you understand what is normal torsion, normal position. You understand that this is lower third of the disc. The fovea should lie along the lower third of the disc, from the lower margin to 1/3 of the disc. Now if it is below that, then we call it extorsion, and if it is above 1/3 to 2/3, then we call it intorsion. Now here you can see that the right eye is extorted and left eye is intorted. So this is what we were talking, that in these conditions you will find that both eyes are torted in one direction. This torsion, this kind of torsion you don't get otherwise by and large, that one eye is intorted and other eye is extorted. You may have one eye extorted or intorted depending upon if you're dealing with the superior oblique palsy or inferior oblique palsy. That can happen, but this is something which is quite diagnostic by and large. Tilt, some of these can come on tilt also, and they can mix up with the superior oblique palsy or inferior oblique palsy. So we need to keep that in mind, that that is also not going to be the differentiating feature. Now etiologies, as we said, the brainstem, strokes are an important factor in older age group, and in younger age group you have tuberculomas. In our country we have a lot of tuberculosis still, and you do see a lot of tuberculomas. Cysticercosis is another very important differential diagnosis. We have a lot of cysticercosis, neurocysticercosis, and of course there will be other conditions like hydrocephalus, adenochiari, trauma. They are not so common, But keep in mind brainstem stroke, tuberculosis, and neurocystic sarcosis. If you have these, you are likely to end up with a skew. Fellow travelers, I said you can have an intranuclear ophthalmoplegia, you have a pretectal syndrome. If you understand that there is inability to, up gaze is limited, down gaze can also be limited, the pupils are semi-dilated, and there is convergence retraction nystagmus. So this is a picture which happens because of the lesions in the posterior commissure. So because these structures are lying close by, so you may have a pretectal syndrome with a skew deviation. Same thing happens with the INO. You can also have a nystagmus, ataxia, and vertigo because it's involving the vestibular structures, but not in all the cases. Clinical features, we have already said that there is a tilt in the subjective visual vertical, SVV, will not go into the detail, and there is a conjugate torsion, we have said AHP. Vertical diplopia can be symptomatic. Head tilt is usually negative, but can be positive in some cases. And important, there is no primary and secondary deviation here because there is no overaction and underaction. So that is one important thing to distinguish from an acquired strabismus, that there is no primary and secondary deviation, which you may find in other conditions. And there is no spread of comitants because they are quite, they stay as they are, and usually there is no pattern also in these. And a good number recovers with time. So you have to give time, as we were talking in the last talk. Very important to give time when you have an acquired strabismus. Now the differential diagnosis will depend upon it is incompetent or competent, will not. Third nerve palsy, ocular myasthenia gravis, acquired MED, Brown's, and mitochondrial cytopathies. All these acquired conditions have to be kept in mind. Most important to look at is acquired superior oblique palsy and acquired inferior oblique palsy, because these two conditions get mixed up very well with a skew. This is showing the same patient we saw earlier. You can see that there is in the left eye is not adducting fully. There is an exo, the left eye is hyper, and it is not adducting fully as compared to the right eye. Now this adduction deficit is because of the internuclear ophthalmoplegia. I was saying that he had probably an infarct. He was a patient with cardiac valvular disease, and probably he had a embolus, and which caused the infarct. So you have an INO and you have a skew here. This is showing the conjugate torsion, you can see very well. Another one, you can also have these incomplete presentations, like this girl also has intorsion. Adduction deficit in the left eye you can see. And if you look at the torsion, the left eye is intorted, but the right eye is not extorted. So it is not important always that both eyes you should have conjugate torsion. It can happen that one eye is intorted, other eye is not there. So you can have these combinations also which may be present there. This girl had, you can see the big tuberculoma on the left side. This was in the midbrain in the pons area. You had a huge tuberculoma. So this was the one, if you don't do MRI, you will miss them. So you need to do an MRI in these cases to image them. This is showing another pretectal syndrome with skew deviation. You can see there is upgaze limitation. But तुमने हमें time ही नहीं दिया ना, तो थोड़ा सा time दो ना. You had problems in midway. And we have another talk. I think she has come, or she? Give us 10 minutes, sir. Thank you, sir. Thank you, sir. So this is a pretectal syndrome. Pretectal means that the problem is in the posterior commissure where the upgaze fibers are crossing. So if they are affected there, so you will have an upgaze palsy. You can also have a downgaze palsy. They are a mid-dilated pupil, and there is a convergence retraction nystagmus. So because these fibers are also there, you may have a pretectal with a skew deviation. So this is important to keep in mind. Again, this is showing conjugate torsion here, and you can see here after 6 months and 1 year, the torsion part has improved a great deal. So you need to give them time. Some of them are going to improve, the torsion as well as the vertical. So at least 6 months you have to give them for recovery. This is showing left thalamic infarct. This older patient, hypertensive. So he had a thalamic infarct, and that gave rise to pretectal syndrome as well as this thing skew. This is another girl, young girl. You see this large ESO in downgaze and EXO in upgaze. And abduction is complete in primary. There is an ESO. Now you tend to think that this is a bilateral 6-nerve palsy or something. But what is happening here? This is a bilateral superior oblique palsy because there is a V ESO and V EXO exo in up gaze, eso in down gaze, always think of a bilateral superior oblique palsy, because very few other conditions will produce an eso and exo in up gaze. So that's something interesting. And she also had an ocular tilt reaction, as we shall see. Now here you can see a conjugate torsion towards the left OTR. The right eye is intorted and left eye is extorted. All right. Now look at later pictures. After 1 year, the right eye and left eye both are extorted. So what has happened is the skew part has recovered, but the superior oblique palsy, which was bilateral, has still remained. Now both eyes have gone for gross extorsion because of the superior oblique palsy, which was causing V-ESO and exo in up gaze because of inferior oblique overaction. So skew can recover, and even torsion can change from an intorsion to extorsion, and even the extorsion part, as you can see in the left eye, has got better. It is not as extorted as it was earlier. This is showing a pilocytic astrocytoma in this case, which was a large one, probably pressing on the superior obliques as well. This is another thing to keep in mind. You can also have an acute acquired competent esotropias, some of these conditions. If you have a brain tumor in a child, if you have tuberculomas, or any other, even after trauma, you can have what is known as acute acquired competent esotropia. A large number are not associated with neurological disease, but some of these may have a neurological disease. And here we had multiple tuberculomas all over. So these are usually caused by cerebellar lesions. So maybe there was a cerebellar lesion in the tuberculomas in the cerebellar part, gave rise to this acute acquired competent esotropia. And you can find this is a large one, ESO, and after treatment, this is also showing intorsion and extorsion. So that shows that this was because of this. So treatment goes: manage underlying disorder, wait for resolution. Prism and botulinum toxin can help. Head tilt and conjugate torsion are difficult to treat. Surgery is mainly on the recti for vertical deviation, so don't be very proactive about surgery. So look at for skews in acquired strabismus, INOs, pretectal syndromes, gaze palsies, acute acquired competent esotropias, include subjective and objective torsion and head position dependent changes in as fourth and fifth step. Very important to look at the subjective torsion in these cases, because that will give you conjugate torsion. So always look at torsion as an additional parameter to evaluate, because we tend to overlook that and we'll end up in difficulty. Suspect them, keep low threshold for suspicion, and order neuroimaging and neurology evaluation, and wait for resolution. If they don't resolve by 6 months, then you need to operate. Thank you.